So today we will be discussing drugs used for Parkinson's disease. So we will mainly discuss the pharmacology of Parkinson's disease, but I will also tell you in brief about clinical features and pathogenesis. So what is Parkinson's disease? It is a neurodegenerative disorder. It is an extrapyramidal motor disorder. So extrapyramidal motor disorder. It is characterized by three features mainly. One is rigidity, that is increase in muscle tone. Second is hypokinesia. Or bradykinesia, which is slowing of movement, also known as bradykinesia. And the third one is resting tremors. Resting tremors means tremors which occur when we are not doing any movement or when the hands are at rest. Resting tremors are characteristic of basal ganglia lesions and are especially seen in Parkinson's disease. Now, what are intention tremors? They are tremors which occur at movement and they are mainly seen in cerebellar lesions. So please remember this: resting tremors, basal ganglia lesions, while intention tremors, cerebellar lesions. Now, why Parkinson's disease occur? It is a neurodegenerative disease, so it is mainly due to degeneration of dopaminergic neurons. Now, what are the other features of Parkinson's disease? So we have stooped posture. Basically, we lean forward, patient leans forward to maintain the center of the gravity ahead so as to maintain balance. Then there is gait abnormalities. It is typically called fascinating gait. Which are rapid small steps. Then there is mask-like faces. So there is an expressionless face and it occurs because of rigidity of facial muscles. There is sialoria or increased salivation, which is also called drooling of saliva. Then there is micrographia, small handwriting. There is soft voice or hypophonia. There are some other features also, like cognitive impairment which progresses to dementia. Then there are sleep abnormalities, especially REM, rapid eye movement behavior disorders. There are sleep abnormalities. There is depression and anxiety, mood symptoms, depression and anxiety, constipation. So if the patients of Parkinson's disease are left untreated, then with time they develop severe rigidity and they are unable to move and unable to breathe. And death typically occurs due to respiratory infections or embolism. So these are the clinical features of Parkinson's disease. Now, etiology of the disease, why it occurs. So most cases are idiopathic. However, it is also said to have a multifactorial origin. So what are the different factors involved? Aging, toxins, genetic makeup of an individual, environmental factors, glutamate induced excitotoxicity. So these are the some factors involved. Now around 10 to 15% of Parkinson's disease is said to have a genetic basis. So in 10 to 15% cases there is genetic basis. So there can be a mutation in alpha synuclein gene. There can be either a mutation in this gene, or there can be duplication or triplication of normal alpha synuclein gene. So Parkinson's is a type of synucleinopathy. Now there can be some autosomal dominant varieties of Parkinson's disease. For example, LRRK2, leucine-rich repeat kinase 2 gene mutation, or UCHL1 gene mutation. There can be autosomal recessive variety of Parkinson's also. For example, Parkin gene mutation. So you have to remember these mutations. Now, what bodies are found in Parkinson's disease? So they are Levy bodies, which are proteinaceous inclusions. So these are Levy bodies. So you have to remember this. Now what exactly happens? There is degeneration of dopaminergic neurons in substantia nigra pars compacta. Degeneration of dopaminergic neurons in substantia nigra pars compacta. So this substantia nigra pars compacta, it sends output to striatum. So the dopamine released from substantia nigra pars compacta reaches the striatum, and there it acts on D1 and D2 receptors. D1 receptors are excitatory, while D2 receptors are inhibitory. From striatum, the pathway goes to globus pallidus internus. Now, globus pallidus internus sends inhibitory GABAergic output to thalamus, and from thalamus, output goes to motor cortex. So, the function of this basal ganglia circuit is to smoothen the motor movements. So, if there is degeneration of dopaminergic neurons in substantia nigra pars compacta, there is Parkinson's disease. Now in Parkinson's disease, it is also said that there is imbalance between dopaminergic and cholinergic system. There is dopamine deficiency while there is relative acetylcholine excess. Now there are many features of Parkinson's disease which cannot be explained by just this dopamine pathway. So why other features happen? Because there are degeneration of other neurons also. For example, degeneration of serotonergic neurons in raphe nucleus of brainstem. For example, degeneration of cholinergic neurons in nucleus basalis of Maynard. Degeneration of norepinephric neurons in locus ceruleus. Degeneration of olfactory neurons. So anosmia is also a feature of Parkinson's disease. Hypoosmia or anosmia, loss of smell sensation. So this is about etiology and pathogenesis of Parkinson's disease. Now next we come to history. So Parkinson's disease was first described in 1817 by a physician, James Parkinson. So he described the Parkinson's disease. It is named after him. Now initially atropa belladonna alkaloids were used for the treatment of Parkinson's disease. But in 1960s, levodopa was formed as the first drug for Parkinson's, and it revolutionized the treatment of Parkinson's disease. So levodopa is the first drug. What is levodopa? It is a dopamine precursor. Levodopa is converted by an enzyme dopa decarboxylase into dopamine, and thus it helps in the symptoms of Parkinson's disease. We will discuss it in detail later. First, we will discuss the classification of drugs used in Parkinson's disease. So we will discuss the classification, And drugs can be divided into two categories: drugs acting on dopaminergic system and drugs acting on cholinergic system. So first we will discuss drugs acting on dopaminergic system. So the first category of drug is dopamine precursor. In this we have only one drug, that is levodopa. Then the second category of drug is peripheral dopa decarboxylase inhibitors. So when this levodopa is given orally, about 95% of it is decarboxylated peripherally in GIT and liver. So it does not reaches the brain to that much extent. Only 1 to 2% reaches the brain. So levodopa is combined with this category of drug, peripheral dopa decarboxylase inhibitors, which are carbidopa and benserazide, so that more of it reaches the brain. Then the third and fourth category of drugs are those which inhibit the degradation of dopamine. So dopamine is degraded by two enzymes, MAO, which is monoamine oxidase, and COMT, catechol O methyl transferase. So we have MAO-B inhibitor. MAO-B enzyme is specifically present in brain. So we have MAO-B inhibitors. In that we have reversible inhibitors and irreversible inhibitors. So irreversible and reversible. So irreversible MAO-B inhibitor is selegiline, and rasagiline. While reversible MAO-B inhibitor is safinamide. Then we have COMT inhibitors, catechol O methyl transferase inhibitors. In this we have tolcapone, entacapone, and opicapone. Now the next category of drug we have is dopaminergic agonist or dopamine receptor stimulators. So they are also in two categories, ergots and non-ergots. So ergots are bromocriptine, pergolide, and cabergoline. These ergots are not used for Parkinson's disease now because of risk of ergotism. We'll discuss this later. Now non-ergots, they are used commonly and they can be divided in three categories. So first is oral. So in oral we have ropinirole and pramiprazole. Second is transdermal patch. In this transdermal patch we have rotigotin. And the third one is subcutaneous injection, and in this we have apomorphine. So for dopaminergic receptor agonist we have ergots and non-ergots. In ergots we have bromocriptine, pergolide and cabergoline. These are not used commonly now. In non-ergots we have three categories: oral, transdermal patch and subcutaneous. In oral we have ropinirole and pramiprazole. In transdermal patch we have rotigotin, and in subcutaneous we have apomorphine. Now the last category of drug is dopamine releaser or dopamine release facilitators. In this we have one drug, amantadine. Now we have drugs acting on cholinergic system. In this we have anticholinergic drugs or central anticholinergics. So among central anticholinergic drugs we have benzhexol, which is also known as trihexyphenidyl. Then we have benztropine, and biperidine. Then we have antihistaminic drugs. In that we have promethazine. So in drugs acting on cholinergic system we have two types: centrally acting anticholinergic and antihistaminics. Now in centrally acting anticholinergic we have benzhexol, benztropine and biperidine. In antihistaminic we have promethazine. So this is the classification of drugs used for Parkinson's disease. Now we will discuss the individual drugs. So first coming to levodopa. So what is levodopa? So first let's discuss what is dopa. So when dopamine is synthesized in neurons, there is a precursor substance called dopa from which it is synthesized. This dopa is converted to dopamine in neurons, and this dopamine is packed in vesicles and released. Now this dopa to dopamine conversion requires an enzyme, dopa decarboxylase. And vitamin B6 is the cofactor for this enzyme. Vitamin B6 is also known as pyridoxine. So vitamin B6 is the cofactor. Now why we can't use dopamine directly for Parkinson's disease? Because dopamine doesn't cross blood-brain barrier. This dopamine can't cross blood-brain barrier. So we have to use a substance which can cross the blood-brain barrier, and then in brain it can form dopamine. So levodopa is such substance. It is levo isomer of dopa, and this levodopa can cross blood-brain barrier, and in brain it can release dopamine by action of dopa decarboxylase enzyme, and dopamine is formed in brain. But what happens, there is a problem that when we take levodopa, around 95% of it is metabolized in GIT and liver. So there is peripheral decarboxylation of levodopa to dopamine in GIT and liver. About 95% of the oral dose, it gets metabolized that way. So only 1 to 2% of it actually crosses the blood-brain barrier. So only 1 to 2% of levodopa crosses blood-brain barrier and reaches the brain. So to overcome this problem, we started combining levodopa with peripheral dopa decarboxylase inhibitor. More commonly, levodopa is combined with carbidopa. So there are two peripheral dopa decarboxylase inhibitor, carbidopa and benserazide. So levodopa is combined more commonly with carbidopa in a ratio of 1:4 or 1:10. So this combination is also known as syndopa, and when this combination is used, more of levodopa is available to enter the brain. So this levodopa plus carbidopa combination is the drug of choice for Parkinson's disease. If the combination is not an option, if only levodopa is in the option, then you have to choose that. But if combination is in the option, choose the combination. Now, what is the usefulness of levodopa in Parkinson's disease? So levodopa relieves rigidity and hypokinesia initially, but resting tremors relieve later. So it provides initial relief to rigidity and hypokinesia. But there is a problem that some features of Parkinson's disease, such as depression, such as dementia, they do not improve with levodopa. So what it relieves? It relieves rigidity, it relieves hypokinesia first. So rigidity and hypokinesia it relieves first. Resting tremors relieve later. Now, if resting tremors are not relieving just with levodopa, you can also add centrally acting anticholinergic for this, because resting tremors are said to be due to relative cholinergic axis. So you can also use centrally acting anticholinergic drug. So resting tremors relieve later, but there are some features, for example depression, for example dementia, they do not improve with levodopa. Especially dementia does not improve with levodopa. So if there are many symptoms given and you have to choose one symptom which does not improve with levodopa, choose dementia. Now what is the pharmacokinetics with levodopa? It is absorbed mainly in small intestine, but its absorption is also influenced by gastric emptying and gastric pH. So it is absorbed in small intestine. Now what are the adverse effects of levodopa? Adverse effects of levodopa are important and they can be categorized into two categories. So central adverse effect and peripheral adverse effect. So first we will discuss the peripheral adverse effects, and the first peripheral adverse effect is nausea and vomiting. So this levodopa gets converted to dopamine, and this dopamine stimulates chemoreceptor trigger zone CTZ area, which is outside the blood-brain barrier, and triggers nausea and vomiting. Drug of choice for levodopa induced nausea and vomiting is domperidone. So drug of choice for levodopa induced nausea and vomiting is domperidone. Why domperidone is used? It is a D2 blocker and it does not cross the blood-brain barrier. Domperidone. Now the second adverse effect is anorexia. Third adverse effect is that it acts on beta 1 receptors in heart and it can cause tachycardia and arrhythmias. So dopamine can act on beta 1 receptor in hearts and can cause tachycardia and arrhythmias. Now fourth adverse effect is hypotension, especially postural hypotension. So this dopamine form can act on D2 receptors in kidney and there can be vasodilation which leads to hypotension. Then fifth is mydriasis or dilatation of pupil. So it acts on alpha 1 receptors and it can cause dilatation of pupils. So they are contraindicated in narrow angle glaucoma or angle closure glaucoma. They can be given in open angle glaucoma if the patient's IOP is normal and there should be monitoring of IOP regularly. So can be given in open angle glaucoma but contraindicated in narrow angle or angle closure glaucoma. Then sixth, it also causes alteration of taste sensation. There is alteration of taste sensation. Now central adverse effects of levodopa. So first is levodopa induced dyskinesia. Dyskinesia means abnormal movements. So levodopa can produce dyskinesia and the drug of choice for this levodopa induced dyskinesia is amantadine. Now levodopa can also produce impulse disorders such as hypersexuality, impulsive gambling, then the third is levodopa produces a general alerting response and excitement. So there can be levodopa induced psychosis. And the drug of choice for this levodopa induced psychosis is clozapine. Another drug which can be used is pimavanserin. Now there are certain contraindications of levodopa. So first we have already discussed, that is angle closure glaucoma. So now we are discussing contraindications. So one is angle closure glaucoma. Second is active peptic ulcer. So it can cause bleeding in the peptic ulcer. Third is malignant melanoma. So dopamine is the precursor for melanin. So levodopa is contraindicated in malignant melanoma. These are the few contraindications of levodopa. Now drug interactions. So levodopa if given with pyridoxine, then the effects of levodopa doesn't occur. The anti-Parkinsonian effect is lost if levodopa is combined with vitamin B6, that is pyridoxine. So anti-Parkinsonian effects are lost. second is if levodopa is combined with phenothiazines or butyrophenones, then the anti-Parkinsonian effect are lost. So phenothiazines or butyrophenones. And the third is if levodopa is combined with non-selective MAO inhibitor or MAO-A inhibitor, non-selective MAO inhibitor or MAO-A inhibitor, then there is hypertensive crisis. That is why in anti-Parkinsonian drugs we read about MAO-B inhibitors. MAO-B is present only in brain, so that can be used with levodopa. But these non-selective MAO inhibitor and MAO-A inhibitor should not be used in combination with levodopa as they can cause hypertensive crisis. So this is about levodopa. Now we will discuss peripheral dopa decarboxylase inhibitor and that carbidopa. So I have already told about levodopa carbidopa combination. So this peripheral dopa decarboxylase inhibitors, they cannot cross blood-brain barrier. So they do not interfere in function of levodopa in brain. But in periphery, they inhibit the peripheral conversion of dopa to dopamine. And thus they make sure that more of levodopa is available inside the brain. So what are the advantages of this combination? So this combination prolongs the T half of levodopa. So prolongs the T half of levodopa and the dose required reduced to 1/4. So 1/4 doses of levodopa is needed. Secondly, there is something called as on-off effect. So with levodopa there is a problem. We'll discuss it. What is the problem with levodopa? That with time the effect of levodopa wears off as there is degeneration of dopaminergic neurons and as there is loss of neurons in striatum also which contains dopamine receptors. There is wearing off phenomena. Effect of levodopa wears off. There is also something called as on-off phenomena. Basically what is on phase is that phase when the symptoms of Parkinsonism are in control, while off phase is that phase when the symptoms of Parkinsonism is not in control. So with levodopa treatment there is on-off phenomena, that is fluctuation in treatment response. So this levodopa carbidopa combination decreases the on-off phenomena. So it decreases the on-off phenomena. Third is it minimizes the systemic complications of levodopa, especially the cardiac complications. So it minimizes systemic adverse effect of levodopa. Especially cardiac complications are minimized. Now there are some problems which do not resolve with this combination or they get accentuated. So problem not resolved or accentuated. So one is motor abnormalities. Sometimes there is dyskinesia and this dyskinesia is more with the combination. So that is one problem. Then there can be behavioral abnormalities. This motor and behavioral abnormalities sometimes can be more pronounced with the combination. Then other problem which is not resolved is postural hypotension. Then the fourth problem is there may be excessive daytime sleepiness. So excessive daytime somnolence. So levodopa carbidopa combination is the drug of choice in Parkinson's disease, except in patients who have these excessive motor abnormalities with the combination. So some patients, they may have excessive motor abnormalities in the combination. So in them, levodopa is used alone. Otherwise, levodopa is always used with combination with carbidopa in patients with Parkinson's disease. Now there are some patients who do not respond to levodopa alone. So some of them may respond to the combination. Now levodopa is also contraindicated in psychotic patients. So one more contraindication is psychosis. In psychotic patients, it is contraindicated as it can worsen the psychosis. So this is about carbidopa. Now we will discuss the degradation inhibitors. So first we will discuss MAO-B inhibitors. So MAO stands for monoamine oxidase. And this MAO-B subtype is present only in brain. This is present only in brain. Now we have already discussed this, that levodopa should not be combined with non-selective MAO inhibitors or MAO-A inhibitors as it can cause hypertensive crisis. MAO-B inhibitors can be used safely with levodopa. So there are two kinds. Irreversible, which is selegiline, and rasagiline, and reversible, which is safinamide. Now this selegiline is partly converted to amphetamine, and it can cause insomnia and excitation. So this selegiline is partly converted to amphetamine and it can cause insomnia and agitation. So this selegiline is contraindicated in patients with convulsive disorder. So this is the problem with selegiline. If selegiline is combined with pethidine, so pethidine we have discussed in opioids. So if selegiline is combined with pethidine, there is a metabolite formed norpethidine. So that can also cause convulsions. Selegiline plus pethidine if given, then some norpethidine is formed more, and this norpethidine can also cause convulsions. Now this problem of conversion to amphetamine is not with rasagiline. So rasagiline can be used in patient with convulsive disorder. It does not get converted to amphetamine. Rasagiline is also said to have some neuroprotective property. Neuroprotective means it prevents degeneration of dopaminergic neurons. Now what is the side effect? They worsen the levodopa toxicity. So side effect is worsening of levodopa toxicity. So there is increased nausea, increased confusion, increased risk of psychosis, so worsening of levodopa toxicity. Now the next category of drugs we will discuss is COMT inhibitors. COMT stands for catechol O-methyl transferase. So these were MAO-B inhibitors. Okay, monoamine oxidase B. When dopamine is acted upon by MAO-B, it gets converted to DOPAC. So if we inhibit MAO-B, there will be more of dopamine available in brain. Similarly, this dopamine is getting converted to M3-MT by this enzyme COMT, catechol O methyl transferase. So if we inhibit this enzyme, there will be more dopamine available. This COMT is present in GIT as well as brain. This is in GIT as well as brain. So there are 3 drugs: entacapone, tolcapone, and omecapone. So this tolcapone is hepatotoxic. So it is banned in many countries. Now this tolcapone inhibits COMT in both GIT and liver. Inhibits COMT in both GIT and liver. So this tolcapone actually helps in prolonging the on phase and minimizing the off phase. And since it acts in GIT also, it improves the bioavailability of levodopa. This entacapone and omecapone, they inhibit COMT in GIT only. So what are the side effects of COMT inhibitor? They increase the toxicity of levodopa. So there will be no more nausea, confusion, psychosis. So they can increase the toxicity of levodopa. How can we minimize this? We can reduce the dose of levodopa. Now there can also be discoloration of urine with COMT inhibitor due to a metabolite. So that is not problematic usually. We have to just counsel the patient that it is due to drug. And you have to remember that tolcapone is hepatotoxic. There can also be diarrhea, severe diarrhea due to COMT inhibitors. They can lead to diarrhea also. So suppose there is off phase, then what can you do? So first is that to levodopa carbidopa combination, we can add MAO-B inhibitor or COMT inhibitor. So that is one thing. And second thing is to levodopa carbidopa combination, we can add dopaminergic agonist, receptor agonist. So we can add dopaminergic receptor agonist. So earlier there was a concept of drug holiday, that when the effect of levodopa is wearing off, you can give some drug holiday and then you can restart the levodopa again after few weeks. But now this concept of drug holiday is not recommended anymore. So you have to remember that this drug holiday is not recommended anymore. Instead we follow these two approach. Either we add MAO-B inhibitor or COMT inhibitor, or we add dopaminergic receptor agonist. We can add both also actually. Now we will discuss dopaminergic receptor agonist. Now in this dopaminergic receptor agonist, there can be ergot or they can be non-ergot. So these ergots are bromocriptine, cabergoline, and pergolide. So these ergots are not used in Parkinson's disease anymore, so they are not used because they can cause ergotism. Now what is ergotism? There is vasoconstriction, due to which there can be gangrene of limbs, toes, fingers, all this. There can be erythromelalgia, that is reddening of limbs, erythromelalgia, and there can be cardiac valvular fibrosis and pulmonary fibrosis. Melalgia, sorry. And there can be fibrosis, so cardiac valvular fibrosis and pulmonary fibrosis. So because of these side effects, these ergots are not used anymore, and pergolide actually got banned due to this cardiac valvular fibrosis. So now we use non-ergots. So in non-ergots, there are 3 categories of drugs: oral, transdermal patch, and subcutaneous. So in oral drugs, we have ropinirole, and we have pramipexole. In transdermal patch, we have rotigotine. And in this subcutaneous injection, so this subcutaneous, we have apomorphine. Now this ropinirole and pramipexole, they are said to slow the degeneration of dopaminergic neurons, and they are actually used in initial phase of Parkinson's disease. This ropinirole and pramipexole, they are relatively longer acting than levodopa, and they are associated with less dyskinesia. So in initial phase of Parkinson's disease, drug of choice is ropinirole or pramipexole. The side effect with ropinirole and pramipexole is that they can cause daytime somnolence. And they can also cause impulse control disorders. Now this ropinirole and pramipexole, they are also drug of choice for restless leg syndrome. So ropinirole and pramipexole, they are also drug of choice for restless leg syndrome. Now what is restless leg syndrome? It is a condition in which when the legs are in relaxed phase, for example in sleep, there is development of tingling, burning sensation, pain in limbs. And once the patient starts moving, these symptoms go away. So the more common cause of restless leg syndrome is anemia. So once we diagnose restless leg syndrome, first we should check for anemia and treat it if it is present. If there is no anemia, then the drug of choice is ropinirole or pramipexole. Now what is the use of apomorphine? So apomorphine is a subcutaneous agent. It is used in rescue of severe off phase. So suppose there is severe off phase, means we are the patient is not responding to levodopa, then it is used as a rescue agent. Now the next category of drug that we have is amantadine, which is dopamine release facilitator. So next category of drug is dopamine release facilitator. The drug is amantadine. So it was initially developed as an anti-influenza drug, but then it was found to be effective in Parkinson's also, and it facilitates the release of dopamine. Now it also is NMDA antagonist. So NMDA is a receptor for glutamate and it is an NMDA antagonist. It also have some anticholinergic property. And it is the drug of choice for levodopa induced dyskinesia. Now what are the side effects? So side effect, it is one ankle edema and the second is livedo reticularis. So what is livedo reticularis? It is bluish discoloration in near ankles. So bluish discoloration which is due to post capillary constriction of veins. So post capillary venoconstriction. Now there is something called as drug-induced Parkinsonism, which is due to antipsychotics. And the treatment of choice for this drug-induced Parkinsonism is benzhexol or trihexyphenidyl. You can also use other centrally acting anticholinergics. So drug of choice is benzhexol. Other centrally acting anticholinergics can also be used. So which drugs can cause drug-induced Parkinsonism? Antipsychotics, metoclopramide, these drugs can cause. The drug of choice is benzhexol. Promethazine can also be used. So you can use an antihistaminic, that is promethazine also. So promethazine has some anticholinergic property also, because of which it can be used. Now we will summarize the management of Parkinson's disease. So drug of choice for Parkinson's disease is levodopa plus carbidopa. Levodopa plus carbidopa. If not in option, you can choose just levodopa. Drug of choice for early Parkinson's disease. Is pramiprazole or ropinirole. They are said to decrease the degeneration of dopaminergic neurons. So they are the drug of choice in initial phase. Then drug of choice for levodopa induced nausea and vomiting is domperidone. Drug of choice for levodopa induced dyskinesia is amantadine. And drug of choice for levodopa induced psychosis is clozapine. So this is summary of Parkinson's disease. Now what to read more, because I don't think this just reading this is enough for your second year. So you should supplement this with reading K.D. Tripathi sir's book Essentials of Pharmacology, and you should also read Katzung. So these two books for pharmacology you should read. If you are in a Western country, you can just read Katzung. In Indian country, you should read both K.D. Tripathi and Katzung. Now for MCQ exams, current trend is integration. So you have to integrate this pharma knowledge with the anatomy and physiology. So you have to read about basal ganglia from anatomy and physiology. Then you have to read about Parkinson's from pathology. You have to read this pharma component. And then you have to read Parkinson's from medicine also. Then your Parkinson's disease will be completed as whole. While reading, also look at some image-based questions such as image of Lewy bodies, the cut section of substantia nigra, both normal as well as in Parkinson's disease. So all that you should know to identify. So that's all. Thank you very much. And you can subscribe to my channel, Dr. Swapnil Rai Pharmacology. Thank you and have a nice day.